way. I don't deserve all that. There are several iconic leaders out here, and you know, when Dr. Atulava asked me to speak about the neurologist's perspective of stroke medicine, and I was thinking that this is like carrying coal to Newcastle. Seriously, this is primarily by the neurointerventionists, and the whole thing is for neurointervention. You know, talking about neuroanatomy, navigating through that is seriously not my cup of tea. And I thought that I'm not going to talk about, you know, how to evaluate, how to localize, and what would be the clinical features of particular stroke syndromes. That seriously is pretty dry, isn't it? So I thought I'm not going to do that. I just, because the whole thing is a stroke management, and so for an ischemic event, and what the neurologists would actually be thinking in their minds when they are dealing with a stroke patient, right? So again, this is not going to talk about it. So there would be certain slides which are, you know, which would be duplicated, infractious, if I might say. So not our stroke statistics is staggering, and all of you are well aware of that. And then the basic adage of, you know, time is brain, so every minute counts, and every minute you don't unclog a clogged artery, there are zillions and trillions of neurons which are lost forever. We're still waiting for, you know, that what Atul was talking about theology tomorrow. So I'm going to talk about noetic science in the upcoming IIMCon in Kashi. So, you know, you have this thing about whether there's something beyond what we know about physical medicine, and whether the brain is entirely just a complex chemicals which are floating by electrical signals, and once the light goes out and everything becomes liquidy and flows out of, you know, the body as well as the soul is flown from the body. We don't know that. I mean, there's a whole lot of gray zones that we don't understand, but still, when we do manage an acute stroke, we understand that time is the basic vertical on which we have based the entire gamut or the tapestry of our interventions. So probably when we are looking at this, and then there are all these physical examinations, practically, you know, when I spent 35 years in the public sector, then there is an emergency, and there are these set protocols, and I do have a DM neurologist who's on call, and we have stroke fellows, and yet, you know, when there is a stroke in court, and you have these people who are descending down to the emergency, you have a physical evaluation, you also have a stroke interventional person there, and everything is done by probably you expect as a rule book. Now I'm on the other side, and I think 70% of the healthcare right now in the country is being done by a private sector, wherein you do not have the luxury of, when there is a court stroke, that you have an intervention, if they are in-house, yes, and on call, and then in-house station very close to your emergency, and there is also a neurologist who can go there. But what actually happens, there is an emergency personnel who are going to do us. And that is now tell me if I'm saying something wrong. Do you all agree with me on that? There are a lot of private sectors here. Yes or no? So yes, there are rule books, but then we do bend them according to the practicality of our existence. And that's the reality of life. And in India, and as is with a lot of developing world, we have a three-tier system of primary, second, tertiary. What we discuss is mostly tertiary, and strokes happen in Timbuktu, where probably nothing exists. Yes, Dr. Renu? So practically, when a stroke patient is coming to emergency, the first contact is an emergency personnel. It's a physician, it may be a surgeon, it may be an MD. And that's exactly what the modus operandi. And we have been when we looked at a telestroke model in district hospitals in the country. So when they come, yes, they would take ABC, which is obviously again a no rocket science. You would take vitals, and then you get a very quick neurological examination. The ones that we always put as a red flag is an alteration in sensorium, which actually puts you on gear that are we looking at stroke when are we dealing with something really major, as compared to a conscious patient with a demonstrable neurological deficit. And then obviously the hints. Now reasonable doubt it is an acute stroke, the person is, put in an IV line, you're taking the blood pressure and the blood sugar, and then the MR or the CT-based protocols, whatever you have in your setup, is notified and the patient is wheeled in immediately into imaging. Because imaging is one vertical which is actually transformed the way you look at stroke from one of nihilism to complete aggression. In total, irrespective of what time the patient has come to you, you have an imaging modality to pick up those patients who have a dying brain but not dead. So the perilous ischemic penumbra, which is the window of opportunity for you to intervene. So that's what happens, and most often these things are not really performed. Yes or no, Dr. Neetu? Right. So in this, yes, there are certain parameters which we need to understand that the saturation needs to be above 94%. And fortunately, in most of the practice settings in India, you definitely have an oxygen portal, put onto the face. And that actually now has a science validity. Initially, there was a kind of thinking, why do you want to give an oxygen? You don't have to do that. But then later, we have a normobaric, we have a hyperbaric. There are a lot of science which has evolved over a period of time, and now you know that you need to maintain the saturation. It's a good clinical practice. And now, what is called as the sweet spot of where you maintain an optimal blood pressure, that's a really holy grail. So, but when, especially for intervention person, pre-IV, post-IV, pre-EBT, during endovascular and post-EBT have all been those zones where there has been a lot of debate. But I think overall the average sweet spot seems to be something like 150 by 100. You don't want to go beyond, less than 140/90. You don't want to go beyond 160 by 100 either in any of those things. So during an intervention, as I told you, pre-intervention and a pre-IVT, you know that you need to maintain it before less than 180/105 and maintain that at a period around that. Maybe actually the sweet spots are different from ischemic and hemorrhagic. And now after interact 4, we know that for an hemorrhage, get it down to 140/90 as soon as possible and maintain it for 24 hours. For an ischemic stroke, when you're intervening, maybe you need to maintain around 150 by 100. And of course, again, the heart rate and then what? The temperature has to be normal. Now, again, there is an imaging talk. I'm not going to get into that. Now, the indications for IV thrombolysis have slightly been modified, and I'm going to touch only those things which have got modified. So now we know that, whether it is American Heart Association or European Stroke Organization, they have evolved. In fact, in the last from 2023 to 25, less than 4.5 hours, the age is now more than 16 years and not 18 years. And this has come out after the SITS ISTR registry. So this has now taken that, yes, you don't have to define an adult as 18 and above, you need to take it as 16. And the upper age limit has been just done away with. And I believe the oldest patient who's undergone an IV thrombolysis is someone who's 98 years old. I mean, I didn't do that. But I believe, I don't know in the southern part of India whether they've crossed 100 years, but age is just a number. And I'm getting older, so I do believe that. Then, and there's a whole lot of meta-analysis in this, which actually has proven that all those things which we have taken as a bugbear, that yes, you treat an older patient, so they will bleed more. You treat an older patient, they won't do it. They may not do well, depending on what the pre-morbid status has been, the frailty index. For a geriatric person, it's always a frailty which matters rather than just a number. So if Trump has a stroke tomorrow, he'll be treated. So you have, and the newer antiplatelets which have come out, and tenectic place is favored over altiplase, and this is the guideline which has come in the European Stroke Organization in 21. Now the dose reduction is not recommended in spite of the fact that it is 0.6 milligrams per kilogram body weight in the Japanese guidelines. We've tried that, there has been some science behind it. We don't do that. According to guidelines, we're not reducing it. And then the CT being normal or shows early ischemic changes, these have remained the same. And then in presence of extensive early ischemic changes, IV may be performed, again looking at the risk-benefit consideration. So again, this has come as a guideline, but in the presence of extensive hypotensities, again, that's a no-brainer. You're not going to do that. And in a non-selected patients, this again has come sort of as a initially a red flag, it now seems to be okay, in the sense that it is accepted in a non-selected patients beyond 4.5 hours in a baseline artery occlusion within 24 hours after stroke onset without the use of advanced imaging, and this has actually come as a guideline of 2024. I thought this is big, and this is I'm talking of IV thrombolysis. And here there has been some more advance which has come between tenecteplase and alteplase. There's always this feeling that tenecteplase does better, but then there is one recent article which said that it may not. So we still have an intervention which comes in probably, and if I have an interventionist, I'm not going to say simply that I give IV and keep quiet when there is a posterior circulation big artery involved. For adults with ischemic changes more extensive than those included, that is, your aspects is bad, 0 to 6, you have to take in age and frailty. That becomes important. Now, in patients 4.5 to 9 hours or a wake-up stroke, you definitely need an advanced brain imaging. Don't get into it if you don't have the capability or accessibility or availability of advanced brain imaging. And in this, the mismatch criteria went into the guideline of 2021, and these mismatch criteria may change. But at this point of time, the age is more than 18 years, and you have a premorbid status, MRS of less than 2. Analysis is really broad, but they've said 4 to 26. Now the 4 and less as taking as a mini stroke, and I differ in that. I'll come to that a little later. And furthermore, after the onset of time is known, and in the wake-up stroke, IVT is initiated within 9 hours from the mid-sleep interval. So there are a lot of radiological parameters, and I think Dr. Balan will talk about this, so I will not get into it, except that they've used really extensive criteria. The importance of this is that after the criteria, they've gone into a guideline sort of things, and a lot of this, especially, and let me tell you, ladies and gentlemen, European Stroke Organization is pretty resistant, and I think the UK is the worst of it all. It takes the guidelines extremely late in the process. When it comes out in European Stroke Organization, I do feel that there has been a way forward in this. So, and if a patient is a candidate for both, in 4.5 to 9 hours, initiate IVT before transport to a comprehensive stroke organization, comprehensive stroke center. And this is a guideline which is obviously makes sense. And so when we're talking about stroke wheels and hub and spoke models, then yes, this is what is practiced, and it's practiced also across India as well. But in a comprehensive stroke center, especially when you have a patient on a cardiac table during a CAP procedure, then there is no really reason to do an IVT. You're going directly with a mechanical thrombectomy. Again, these are common sense situations, and you take your decisions. Now, you do have this both the thrombolytic agents available, and I think India has actually been the way forward in this. It actually has shown the way. And in fact, it's been, I think, Make in India concept that tenecteplase was first, in fact, got the guideline into the guideline and recommended by DCGI way back. And now the whole world is accepting it, and it has actually come into the guidelines. There is a difference in the dose. So actually, the immune stroke, guidelines, according to the Ministry of Health, differ slightly from the DCGI in the sense that DCGI still stuck to 0.2 milligram per kilogram body weight. The Ministry of Health, even in updated guidelines, have said 0.25 milligram per kilogram body weight, which is in tune, which is there in the international guidelines. So we have this as I will not say as an alternative. In fact, it has gone in as a go-to, and alteplase as an alternative, in spite of all the a little bit of caveats of lacunae in the science in terms of evidence, just because alteplase has been in there since 1995, and tenecteplase has just about come in as a new kid of the block. And then we have, now we have, I think this would be a little bit of a repetition, so I'm going to skip this. And is this changing? Okay. Now we come to the contraindications. The first one they said is, the mild non-disabling strokes. Now it persists. I really don't know. So I personally don't think this is really a guideline to be adhered to. The first presents the trial, which was actually brought in by Pooja Khatri. She's a good friend of mine. She's from Cincinnati. And even she had a little bit of reservations when the trial was actually published, in the sense the mild non-disabling is a little bit of a subjective nature. And it's a dialogue between who's had a stroke and the clinical validity of actually substantiating it by an examination. So for a neurologist, your criteria of NIHS is, there are three important NIHS parameters which are not counted into it. Whether it is aphasia, whether it is hemi-neglect, or it is hemi-anopia. It is never calculated into a major NIHS. None of them actually meet NIHS criteria of 4, and you know that they are taken as a major strokes. But then a loss of dexterity of a right hand for a surgeon, for a neurointerventionalist, when the NIHS you can't even calculate, would you take it as a mild stroke? So it actually depends upon what the patient feels and what the clinician decides. So to me, a stroke is never really mild. It's a warning to something happening major, and it is a God-given opportunity to correct before some serious damage can happen. So when there is a mild and non-disabling, even if the large vessel is not included, I would actually go ahead with thrombolysis, though it is not an event, and that's my perspective as a neurologist. But then you do have a flip side. There are people who argue that if I do that, there could be a bleed. And now there is science to say that when you're treating a non-disabling stroke with a very small ischemic focus, and that's what you really think it is, they're not going to bleed that as well. So I think I would go ahead with it. But then, according to the criteria, then you need to decide, and it is actually between you and the patient. When there is a mild stroke and there is a large vessel occlusion, and you know that when a stroke patient is coming to the ER, the stroke imaging is a continuum. You're not just starting with a panoramic image of a CT or an MRI, doing the vessel imaging. That's part of a protocol, isn't it? And that's what all of us do. You need to do it. So unless you're in a district hospital and you don't have a wherewithal to go beyond the panoramic imaging, and you're only looking whether there's ischemia or a bleed. So when you do a vessel wall imaging and there's a large vessel, then you're not even waiting, isn't it? That's just really a bomb to explode before if you don't act in time. So there we are, and then we have the other contraindications. Obviously, there are some more in-your-face contraindications. You won't do that, but prior ischemic stroke within 3 months is now really going away, unless it's huge, it's hemispheric, and there is again a pre-morbid status of the MADRS of 4, and there is frailty. Yes, but if within the last 3 months it was a little lacoon, I'm not going to take it as a contraindication. So these are relative. So look at a case, as they happen, and the recent intracranial spinal surgery. Now I see it as the biggest bugbear. When you're looking at a hypertensive bleed, my very good friend Dr. Subhash Paul, always used to say that there's a Mr. Lucky and a Mr. Unlucky. Both are hypertensive, they're diabetic, they smoke like a chimney, and then they've had a heart attack and they've been on antiplatelets. And one had a little lacoon because of his wayward behavior, and a behavior is something which we don't even touch upon in stroke medicine. And the other person had a massive bleed and became vegetative. Now, what really determined this? Is it the extent of hypertension? Is it genetics? Is it epigenetics? We don't know that. But then it is true that just the same parameters, having a hypertension doesn't mean the person is never going to get a heart attack or will not have an ischemic stroke. So just because he's had a bleed in the past, why are we going to say that he will not give the thrombolysis? What is the potential of a bleed if I do that? So the science which has eliminated after that is to say that they really don't bleed that much. Unless the bleed is because of amyloid angiopathy or they deep lower bleeds. Otherwise, if you have a putaminal bleed, a thalamic bleed, it just happened 6 months away, and it has just left a little slit and now has come with an ischemic stroke, especially a large artery, definitely those with IVT may still hold back, but EVT, absolutely no contraindication. So there we are, and then of course the tumors which have a bleed. Coagulopathy, please, and again this is a personal experience. There was a case which came to the emergency. It's 45-year-old, again, hypertensive, diabetic, the usual list, the check boxes you keep quickly, wheeled into. This was at 3 a.m. in the morning, and he was wheeled into the practice that I am in is MR based. You can have a CT based also. Was taken to the MRI, and there was a tiny little, there was a diffusion flare, mismatch flare. There was no ischemia. Fits the criteria, and then the blood work has been sent, and he was thrombolized with tenectic place. And then about an hour or 2 hours later, there was a dip in sensorium. So quickly he was taken in, and again there was a massive bleed. And then the relatives came out that he's a patient with chronic liver disease, has actually had hematemesis in the past. The relatives didn't even disclose that. The wife didn't disclose. There was an issue with insurance because they can't talk about alcoholics liver disease and alcoholic cirrhosis, which actually would be an item. I think whoever is dealing with insurance policies in the practical sector would know that. And once this thing happened, and then the family was up in arms against, आपने कुछ दिया है इसीलिए तो ये हुआ है. And then the all thinking, and the platelets were just barely 40,000, and then the gastro guys who was treating in some other hospital was contacted, and she went into surgery. These things happen because you are depending upon the history which is given by the caregivers. You don't know. They may not come up with everything you have, so you will have problems when you sometimes you deal with these patients. But remember, in a dengue, epidemic, please check your platelets. They may not even tell you that. And there are now dengue cases without fever. They just have body ache and fatigue, and they have this being positive. Platelets are a big red flag, and be very careful about that. And of course, when you do have all this which are known, then you will see the 400 milligrams percent is now become relative. It's not a strict contraindication. But hypoglycemia is strictly a stroke mimic. Not going to treat that, but you will end up treating sometimes. This is okay. So the other recommendations are here. Of course, LP is no longer a problem. We'll come to that a bit detail. And sickle cell disease and eye disease, and I guess retinal stroke and the CRAOs are still that kind. We don't talk about spinal strokes and we don't talk about the retinal and the CRAOs. There is also a lot of evidence which is coming up, but there is a way to manage, and the interventionists also have a big role in that. So the thing is that they don't read textbooks and come to you. So there are a lot of difficult situations which keep happening. So you have this unknown things which we've already said. But one of those useful things, and there's actually a slide which I asked Dr. Patrick Michael. He's from Switzerland. He's a really big, good strokeologist. And he's given this, we usually do this diffusion and flare. But then there are situations where you can just do a plain CT and clinical mismatch. So the mismatches are I think the trajectory of mismatch science has evolved to something which suits your practice setting. Where you just have a plain CT, you can still have a mismatch there. Versus when you have a vessel imaging, you can have a mismatch. You have CT angle mismatch. But at the commonest mismatch which we use is a diffusion and a flare mismatch. Basically, again, saying beyond 4 hours, you have a flare image which becomes positive. This is a Thomalas great paper saying that number needed to meet is 9. And the minor and major thing we have already told you. The stroke mimics is something that you will treat a stroke mimic. As a neurologist, I have. And I've done this at AIMS Delhi, wherein you actually put in you look for the blood sugar. Sometimes in our emergencies, the strips that are there, they are old. There could be a possibility they're there in the atmosphere, they don't work. So I've actually treated some, in fact a high profile person who actually a diabetic, came in altered sensorium and one side not moving. CT normal, big red flag to me actually. At that point of time, in 11 o'clock in the morning, when everything is buzzing and active, and the blood pressure is fine, blood sugar is 135. So the resident says, "Madam, this fits all the check boxes are there." So we leave at the place, and this was the right place there. The patient was shifted to the ward, and she was having gum bleeding. Still in order, infusion is on. I said something was not fitting right, and we repeat the sugar. The sugar is 25. We quickly pushing 25% of glucose, and she wakes up, and the family is really very happy. We are magicians. We never disclose what we did. But then these are mimics which you will manage. So the actually tell you, take out posterior circulation. Pick up those tiny little ischemic zones or very early ischemia. And MR also may actually miss out in different studies. They say 6 to 16%, or sometimes an MR may miss it. So therefore, there you go. Very young, very old, I've already told you about that. Pre-existing conditions, I think, is actually the ones which will determine if you're dealing with these out-of-body situations. And then, bleed risk, and I'll quickly go through this, that a subacute ischemic stroke less than 6 weeks, it's small, less than 10 ml, go ahead. Silent and subacute, always fine. Even in a hypertensive bleed, you'll find this leukoariosis, lacunes, you have black holes, not just in MS, you'll find an ischemic even in stroke patients. Less than 10 ml, it's okay. Moderate to severe leukoariosis, which is basically Fasciculus grade 2, you go ahead. And history of SAH with a completely treated bleeding source you can. History of hypertensive, as I said, is a relative. It remains relative. Subdural, if spontaneous, don't ever do it. Hygromas, never symptomatic, is okay. In fact, just 2 days ago we did that. Several microbleeds depends upon the size as well as the number. And if you're suspecting amyloid angiopathy, don't do it. They'll bleed, even for stroke prevention. Active intracranial malignant tumors, intraaxial tumors, bleed risk, don't do it. And systemic malignancy, when there is active bleed, don't do it. And when there is obviously life expectancy which is less, don't do it. And I think in aneurysms, you know better that this is the protocol that we do that. And the intracranial AV malformations, cavernoma, no, but DDA and capillary telangiectasias are fine, and go and pick them up because you're going to do your MR imaging, which includes this vessel imaging. And antithrombotics, I guess ticagrelor with aspirin would still be relative. I haven't seen people bleeding with that, but the others, clopidogrel aspirin is now taken off. There's been a lot of studies which said even this DUAP is okay. And aspirin, of course, don't even bother. And the others, when we have a lot of people now on NOACs, so I don't have. How many of you are using TT and ECTs? Tell me. Anyone? No, we don't. So people are coming to you with apixaban and dabigatran. So what do you do that? Rivaroxaban, especially the cardiac guys love rivaroxaban. So for me, again, a practical solution, I do APTT, the patient is on dabigatran. If I don't know when the dabigatran was last taken, if they've taken it beyond 48 hours, fine. But if we don't know and they don't know, then, because a lot of people are effacing and the family has no clue. So in which case, do APTT for dabigatran and PT-INR for BANs, that is rivaroxaban and apixaban. So if that's fine, less than 45 in APTT, less than 1.7 in BANs, that is apixaban or rivaroxaban, I go ahead and thrombolize. Using idarucizumab, it has been said, but that's a pharmacological reversal. There is a lot of data that you can do that in dabigatran and do it. And there was a question that one of post-day neurologists posed to me a week ago. She's a faculty in one of the big institutes in Delhi. Father has AF, new onset AF. He fits the criteria, he needs to be on a NOAC. She says, I don't want to put him on a NOAC because there's no reversal. If there is a bleed, what would I do? I put him on warfarin. To me, it's ridiculous because VKA, vitamin K antagonist, is an extremely tight rope war. Now, and for me, she says, Andexalat is so expensive, it's not available. I'm not looking for Andexalat because these NOACs are short acting. You can manage, and I'm pretty comfortable how you manage those things. So just let's get it over with. I think most of you know. LP, all these things are no longer contraindications. And pregnancy, postpartum, we've been managing these cases for long now. So none of them really are contraindications. But when we have to look at this IPG, these things we do manage. I have not seen angioedema, but time and again there may be cases. And only when they are really severe that you have to manage. But otherwise, it is you can manage it very well just by a conservative approach. Otherwise, you have to do tracheostomy. The biggest bugbear I think is what? What is the big bugbear? ICH, isn't it? The symptomatic ICH, whether you're doing with IVT or intravascular thrombectomy. So here, and how do you do that? ICH is responsible. Clinical deterioration, which will be 4 more points on NIHSS. Within 72 hours, than not, it is actually the bleedingness, the frailty, the underlying situations in the MRI that you can actually pick up that probably determine, and also the extent of blood pressure. I think that's one single parameter. If you control well, you can. So the risk factors have all been established here, which we definitely will have to have them in the back of our mind when you're dealing with this. And there are a lot of ways to subgroup them, but what we are interested would be the parenchymal type 2 and type 3. Not so much the hemorrhagic conversion. These are the guys which are big. And so whenever there is an early neurological deterioration, the N is defined as deterioration sensorial within 24 hours after an intervention, or a 4-point increase, but actually it's a sensorial depth. And there are a lot of reasons why N occurs, but if it is because of ICH, there are a lot of risk scores. You have the MSS, and there are a lot of them, HAT score, and then you have GRAF, SIGA, TRI, DRAGA, and multiple. But essentially there's an overlap depending upon, again, the age comes in, but the extent of blood pressure, diabetes, or the extent of hyperglycemia, the extent of leukoariosis, and then throw in a bit of atrial fibrillation and others. Most of them are overlap scores, but then after all of them, again, this is a take home which said that in spite of that, you need to actually give them, because the risk benefit tilts towards the benefit on intervention. So management, there is vital functions, you stop administration, you still on flow, and then you reverse the coagulopathy. There's a lot of medications which are available, but primarily this is what we do. If it's a push, then it takes place, then you can't do anything, but if there's alter place, you stop it, you check them, you do a CT, check what you're dealing with, extradural, subdural, subretinal, or ICH, and you will need this. Most often than not, we see PCC. FFPs, when you don't have that happening, platelets you can give when you're up against the wall, but it is actually PCC. In fact, PCC4 would be the best. There's not much of evidence which has come in with transaxan, or the epsilon aminocaproic acid. The last that I know of with the transaxanic acid is still an ongoing trial. I don't think a lot of positivity coming out of that. And then you have the factor 7A which came and went away. So in the END, the differential diagnosis, you have all these things to consider before you're jumping in. Then when you have an END, just get a plain CT immediately. The prevention is very again important, that you have hypertension and hyperglycemia are in your hands, which you have to keep them optimal. This you may find, but I think this is more often you see when you do an intervention in terms of reperfusion. On and off you may find that. Again, blood pressure, monitoring is an aggressive control, optimization of BP is probably the take home in all these things. These are very minor and very infrequent side effects. Sometimes we see and we sort of don't really. But I think this is the holy grail. Still we're trying to find a sweet spot, but what I've said before is where we are at this point of time. So I'll end here and say that never ever give up. And that's my perspective of stroke management when you talk about ischemic stroke. Thank you.
I need to run it from here. So just connect. Good morning, all delegates, uh, my seniors present in the audience. I thank the organizers, especially my dear friend Dr. Atullah Vajpayee and Dr. Nanda, to give me this opportunity to stand before you and share some views. And this looks like a complex topic. I will try and make it easy for all of us. So AI is the real thing. Actually, if you say AI in Hindi, it is I. I, where I come from, Maharashtra, is mother. So I think this is going to be our mother in the near future. So this talk is primarily just around imaging, but how we can streamline the flow of the imaging to suit our purpose and of the patient. That we will see.
Can you sit down so we go behind the sit?
Okay. I think there is some points in terms of either day. This is a bit of a technical glitch. I think in the times of AI, we expect these more often. Yeah, because the human intelligence will go down and our dependence on AI will come. So after 5 years, we'll not know how to read a CT scan, right? Because you will be depending on the AI. Shall we have? So here we know that basic CT scan is the workhorse of stroke imaging, and on that we have a CT angiogram, we have CT perfusion. I will not go into detail with all those things. I think there is still some problem with this also. Yeah. So, and then the other imaging which is favored by most of us who want to show the infarct on the acute stroke is MRI. I think I deal with it more often that CT scan doesn't convince any patient or relative that you have a stroke. Nor the clinical deficit convinces. So I think the MRI convinces them very quickly. They see something on that and then they're very happy. And then based on that, whatever you show, that angio, contrast and enhance all that, that is fine. But they need to see the infarct on the imaging. That's why the MRI. And the second role is basically when you have that wake-up stroke. So diffusion flare mismatch, right? The other modalities are all supplementary and complementary. So what happens on the non-contrast CT scan? Just to revise that you have some signs which are called as signs of early ischemic stroke.